Yes, my name is David Boehner. I am at Ohio State University. I'm an associate professor of emergency medicine. I started as a medical student shadowing some radiologists, and they explained to me some of the differences between the different modalities of CTs, X-rays, and ultrasound, and I developed my interest in medical school. I started in residency. They had a large refrigerator-sized ultrasound machine that no one knew how to use. I started using the ultrasound, took some courses, went back and got my RDMS, which is Registered Diagnostic Medical Sonography degree. It's a tech degree. And then since then I've been teaching medical students, residents, and fellows how to use ultrasound and embedding it into an ultrasound program here at Ohio State that we call the Ultrasound Academy. Well, there's always a need in medicine to know what's going on underneath the surface. And so what's happened is that these devices have become smaller, portable, less expensive. And the 20th century model with ultrasound was that there was one machine, one operator, and they're in a suite. So the patient goes up to the suite to get their ultrasound. The 21st century model is there's one machine, multiple operators, and the machine actually goes to the patient. There's multiple uses that you can do in clinical medicine, and we use what we call focus ultrasound versus comprehensive ultrasound. Comprehensive is the traditional model where there's a sonographer and a radiologist or cardiologist that are looking over the exam. A focus exam is performed by the clinician at the bedside. So for things, as you mentioned, things such as patient safety, there's somebody that needs an ultrasound or needs a central line or access, you can actually see the vein and watch the needle go into the vein. If somebody needs any type of procedure, you can actually watch it under direct visualization rather than having a blind procedure just based on landmarks. And then there's the need that there's a patient that's critical that can't be transported somewhere besides at the bedside, and so you have a diagnostic imaging tool that you can use to see underneath the patient's skin what's going on, such as, is there a heartbeat and a cardiac arrest? Is there fluid where there's not supposed to be? A patient that has trauma, that they may have a ruptured spleen, do they need to go to the operating room? You can look with ultrasound and find, is there fluid where there's not supposed to be? So basically critical care, procedures, and another area that we use in the emergency department a lot is the pelvic scanning. Patients that come in with pregnancy, bleeding, cramping, and you want to know where the pregnancy is. So the devices are capable of seeing things such as appendicitis, but again, when the machines get smaller, they're not don't have the capability of some of the larger machines, and so you could do that. That's not one of the focus uses that our college, the American College of Emergency Physicians, advocates. So it is possible to do, but it's not widespread. And I think that part of that is that we work in the emergency department. We're not working in a vacuum, and so we have to work with surgeons, and at least with adult surgeons, they are more comfortable with the use of CT scan for appendicitis than they are for ultrasounds. So I think there's some big difference between CT scans and ultrasound. CT scans are expensive. They use ionizing radiation. They don't harm the patient. The patient doesn't feel anything, but there has been some recent reports as far as long-term issues with radiation exposure. Ultrasounds are smaller. They're at the bedside. They use non-ionizing mechanical energy, so they use sound waves to image. They're portable. They're at the bedside. They can give you some of the same information. The big difference between the two is that ultrasound is operator dependent, and that means that the operator needs to know how to use the buttons, understand the image, and make a quality image. And the images are not as standardized as, let's say, a CT scan. If you get a CT of the abdomen and pelvis, they're going to give you the same 120 images in the same order every time, no matter if the patient's 400 pounds or if they're 100 pounds. With an ultrasound, you don't get that same level of consistency. There is some operator dependency, but in the right, correct, trained hands, you can get similar quality of data